What physical therapists need to know about hamstring strain injuries? All right, why do we care about hamstring strain injuries? Well, the big reason is because it's usually the number one most common injury in most field sports. So things like football, things like soccer, very, very common to have a hamstring strain. Believe it or not, even baseball, hamstring is usually that number one injury, which is always hilarious. The other piece that's really important about hamstring strain injuries is they often occur right in the middle of a season. So that's super problematic because patients don't know whether or not they can get back, when they can get back, when it's safe, right? So in today's episode, we're going to go in depth on what physical therapists need to know about this common condition.
All right, so what are we going to talk about today? Well, we're kind of breaking up the hamstring strain into two parts. Part one, which is we're going to talk about right now, is what physical therapists need to know. Part two, which will be a future episode, is a little bit more about examination and interventions in rehab. But we're talking about epidemiology, pathoanatomic features of hamstring strains, risk factors for acquiring or getting a hamstring strain, the clinical course, and return to play and re-injury risk. So getting into epidemiology, this statistics for this are based on this paper from 2023 in the British Journal of Sports Medicine. Incidence and prevalence of hamstring strain injuries in field-based team sports, a systematic review and meta-analysis of 5,952 injuries from over 7 million exposure hours. So a lot of good high volume of research in this paper. So it's a massive systematic review with 63 included articles. Like I said, there's 5,952 injuries from over 7 million exposure hours. And the sports included were soccer, rugby, Gaelic football, hurling, field hockey, and Australian football. So certainly not a paper that was written in America. These are a lot of sports that are popular outside of America, but I think super cool field-based sports give us a good insight into hamstring strain injuries.
Yeah, BJSM, huh? Gaelic football. Don't even know what that is. Signs that you're an American, right?
Totally. So epidemiology, hamstring strain injuries are common in activities that involve high speed running, jumping, kicking, or explosive lower extremity movements with a rapid change of direction. So kind of like Dan had mentioned in the intro, it's very common in many sports. And I think surprisingly for a lot of people that treat baseball players is that hamstring strains are one of the most common, if not the most common injury in baseball. And I think it's probably because what I just said, it includes explosive high speed running. Usually once the batter hits the ball, they're running for first base. That's a very common place to have a hamstring strain injury. So we see it with that type of activity. The incidence is 0.3 to 1.9 or 0.81 per 1,000 hours of exposure. It represents 10% of all injuries in these sports. That's really high, 1 in 10 there. It showed that male soccer players had the highest rate of hamstring strains. Male tends to be a little bit higher than female, a difference of 5.97 per 10,000 athlete exposures versus 3.13 per 10,000 athlete exposures in females. And my best guess, I could be wrong on this, is just that where hamstring strain injuries occur with such high explosive movements, I think we still tend to see men perhaps a little more powerful or faster with sprinting than some of the female counterparts. That's not to say that they're any better at sports or anything like that. It's just that sometimes with that increased power, perhaps we do see hamstring strains correlating more with men for that reason. And then the other thing is a professional soccer team of 25 players. This is pretty crazy. Can expect about 7 hamstring injuries per season. So huge issue, like Dan said in the intro, and something that if you treat athletes, you're going to see and you need to know way more about. So excited to talk about it.
It is kind of crazy, right? I mean, I think about this at the professional sport level. And a lot of that is because just working at Champion with Mike, and hamstring injuries are a real issue. So if you're paying these athletes millions and millions of dollars, they get a major injury like that. Think about that money that's lost. It's kind of crazy. And the stress that goes on the player and the team to get that individual athlete back. That's a ton of injuries. It's kind of crazy. Pardon the interruption, but it looks like you're a hamstring guy. Is that true? Do you want to learn about hamstrings? Because I got something I think you're going to enjoy. It's an evidence-based cheat sheet going over hamstring strain injuries. And my promise to you is I'm going to catch you up to date on the latest evidence about hamstring strain injuries under 10 minutes. Staying up to date as a clinician is a pain in the butt, just like a hamstring strain injury. But it doesn't have to be hard because now we have a solution. We go over all the heavy hitters like incidence and prevalence, pathoanatomy, as well as risk factors, the clinical course of hamstring strain injuries, whether or not your patients need surgery, re-injury risk, as well as return to play. Best yet, this cheat sheet is 100% free to download. I'll leave a link in the description where you can check it out and download it right now. Like I said, the goal is to catch you up to date in under 10 minutes. Now, back to your video.
Continuing with the epidemiology. So talking about the prevalence, over a 9-month period, the prevalence in this paper that we're talking about was 13%. Higher rates in match play versus practice. And I think this just highlights the theme that it's the intensity of running and cutting and leaping or reaching with a stretched out leg that will increase the chance of injury. So in match play, presumably the intensity is higher than you can replicate in practice. And that's probably why we're seeing more injuries. Maybe you're a little more fatigued in a match, but I think those factors probably influence that. There is a higher rate in older athletes and athletes with a previous hamstring strain injury. So we will talk about the changes to the anatomy. And I think that one thing that we see is a shorter fascicle length tends to be associated with a hamstring strain injury. And, older athletes perhaps are falling into that category, as well as athletes who had a previous strain. The tissue changes and it becomes more susceptible. So we'll talk about that. But those two cohorts are at increased risk. The typical time loss after this injury from sport is between 3 and 28 days. So that's a pretty large range. And I'm always actually fascinated. That seems quick when we consider like other pathologies. On the long end here, we're talking about a little less than a month. So the typical time loss is between 3 and 28 days or more, depending on the severity of the hamstring strain. And I always find this to be pretty interesting. I feel like that's a pretty short amount of time, but we also know that there is a high rate of recurrence. So it's possible that we're getting people back too soon, but that's generally what you'll see in the research and what this paper points to as a return timetable after the injury. Re-injury rates range from 13.9 to 63.6%. So that's a huge range. And I think that's just because they included a lot of different papers in this systematic review. So keep that in mind. There'll be a lot of variance, but even on the low end there, 13 to 14% is a very high recurrence rate. And then up to 63%, that's massive. That's close to 2/3 of people getting back are going to sustain a re-injury. So those with a history of hamstring injury have a 3.6-fold increased risk of sustaining a future hamstring injury. So hopefully when we get over and talk about the treatment of this in a future episode, our treatment strategies can reduce this re-injury risk. But as of now, this is what the paper is pointing to for what we're seeing in terms of re-injury. So I think important stuff. And you should definitely know that going in. We should be a little bit more cautious, I think, with these folks in return to sport.
Yeah, I think those re-injury rates are just like crazy. And one of my personal thoughts too is that these strain injuries are sometimes hard to rehab because they feel better quickly. It reminds me of like a lateral ankle sprain. The recurrence rates are so high, right? And they recur out of nowhere. So it's like, I feel great. Oh, I strained my hamstring. And that's really, really tough to manage. And a lot of what I do is I just try to educate patients. You kind of go in there with a lot of patient education, just say like, hey, you feel pretty good, but you just kind of got this injury 2 weeks ago. Your recurrence rate is higher. I'm sure we'll cover this later, but the further out you are from the injury, the greater the reduction in re-injury risk goes. And a lot of these are happening mid-season. So we're constantly seeing patients that want to get back to play on, like, let's say Friday, and it happens on a Monday. We're like, oh boy, right? And then we'll see how this goes. And sometimes they feel great and they get back and there's not a problem. But I always just try to educate patients to say, like, the faster you get back, the greater the risk of re-injury is. So we're oftentimes thinking about short and long-term planning, like, hey, is this game coming up actually any important? Because the 3 that are after that are actually very important. And if you play this one and get re-injured, there's a chance it just sticks around for a lot longer. So I just think that the patient education is really important, letting them know that despite them feeling really good, they might not be fully ready. They still have that risk. The longer they wait, the better. But the other part is, like, a lot of these folks are not going to wait for the rest of the season, right? They're not going to stop playing like high school sports or collegiate sports because they have a hamstring strain injury. So it just ends up becoming very tricky from that standpoint.
So pathoanatomic features. The biceps femoris is the most commonly involved hamstring muscle. It accounts for 79 to 84% of hamstring strain injuries. So that's nice to know. Most commonly occurs at the myotendinous junction during running. So you'll see a proximal hamstring strain injury fairly commonly at that junction between the sit bone, the tendon, where the tendon originates, and the muscle belly. So you'll look for it up there. And that's the most common site of swelling and edema. So you might see bruising up there. Definitely something to look at and kind of track over time. And then with the mechanism, it's an eccentric contraction during the swing phase is often the mechanism of injury. And then sometimes there's a quick contraction where you go from that eccentric contraction to concentric, and that quick change of force is often another mechanism of injury. Less common, but more significant and longer recovery timelines are stretching type injuries. These account for 19% of injuries in Australian football. Like I just said, they're associated with longer recovery times, and this often involves the semimembranosus. So we might see this more in sports like gymnastics or dance, or maybe different types of martial arts where you are in a very lengthened position, you're overstretching. And like I said, those tend to be a little more significant. So depending on the patient population, you may see some of those, but I'd say most commonly what we see are those more sprinting based strains, like what you'll see in baseball, soccer, field based sports, essentially. So just be on the lookout for those two different types.
And just to add, it's been a while. I did look into this research at one point, but it's been years. Like, what is the most common mechanism of injury for hamstring strain injuries? And one of the things that's interesting is they often occur eccentrically. So if you're running and your leg swings through, then you have to stop your leg before it hits the ground again. That's when a lot of these injuries are occurring. I think that's kind of a tough thing to wrap your brain around, because I think the common thought is that these hamstring strain injuries occur when your foot hits the ground and you have to propel yourself forward, which they certainly occur at that time point. But depending on the study you read, sometimes that eccentric portion actually occurs, creates more injuries than the concentric portion. And I think you may talk about this in future episodes, but maybe one of the reasons why eccentric exercises are probably a good idea for these folks, because they're getting hurt. That mechanism of injury is an eccentric contraction. They're not able to control well. So getting them back up to snuff to be able to handle those eccentric forces, probably an important thing. Hopefully I didn't steal too much of your thunder, Kevin, because I know that you probably get into this at some point.
Yeah, totally. Continuing with pathoanatomic features, injuries can also occur in the different hamstrings. It's not just the biceps femoris. So in the semitendinosus, although it's less common, it generally appears, if it does occur there, as a larger, more distal tear. And it can also appear as a myotendinous tear with edema as well. An increased anterior pelvic tilt may place the hamstring muscle in a more lengthened position, which might also increase the likelihood of a hamstring strain injury. Timmons et al. Compared 20 recreational athletes with no history of a hamstring strain injury to 16 elite athletes with a history of a unilateral hamstring strain injury, and compared ultrasound imaging measures of the biceps femoris in graded isometric contractions at 0 degrees of knee flexion, 30 degrees of knee flexion, and 60 degrees of knee flexion. And what they found, they were looking at the muscle architecture, and they found that it was different after a hamstring strain. So the group that had the strains, their hamstrings actually did look different. They had shorter fascicle lengths and greater pronation angles. And they thought that these anatomic changes may contribute to reduced muscle function and increased risk of re-injury. And I did highlight the shorter fascicle length because, as Dan was just saying before he stole my thunder, the reason why we think some of these eccentric hamstring exercises are helpful like Dan said, this is how the injuries are occurring, but we're also having a change in the structure of the hamstring. And one way to increase fascicle length is by eccentric strengthening. So we're trying to perhaps make the muscle look more normal or more similar to like it did before the injury. So I think there are a few reasons probably why we see hamstring eccentric exercises being recommended. And it's probably a combination of getting back to what caused the injury, but also laying down some more normal anatomy. So it looks more like the uninjured group versus the injured group. So I thought that was pretty interesting. So more on the pathoanatomic features. If you are watching this, you'll see an image here of a very bruised distal hamstring. And this is what you'll see in the clinic. It's fairly crazy the amount of bruising that someone might present with after a hamstring strain. It's almost alarming when you see it for the first time. You're like, holy crap, this looks so bad. But it gets better fairly quickly. And I think one thing that's good to do is look at the change in bruise size over time. You'll often see these in the myotendinous strains of the biceps femoris and semitendinosus. So you'll see it up by the sit bone area. One important thing, although it's associated with longer recovery times, it's not predictive of longer recovery times. So if you have someone with a really bad bruise, we're not diagnosing the severity of the injury based on the amount of bruising. I think it correlates, but it's not predictive. It's not like the worst bruise takes by far the most time. So it should be interpreted in the context of imaging, if appropriate, and clinical examination. We will talk about this at some point, but one thing that you don't want to miss is if you have like an avulsion fracture of the ischial tuberosity, and oftentimes that's going to require surgical fixation. Or if it's a younger athlete, perhaps there's like a growth plate issue going on. So sometimes imaging is warranted. And I think if you're worrying about that, you should definitely refer for imaging. It doesn't hurt. It's one of these things where if surgery is going to be indicated, I think similar to a biceps tendon rupture or an Achilles tendon rupture, it's probably better to have surgery sooner rather than later. So for me, I saw a patient fairly recently with a clear defect, like the hamstring had, a pretty significant strain, saw a little bit of a defect in terms of a divot in the hamstring. And I was concerned that it was like a grade 3, something that might need surgery. I sent them to a local doctor we have who treats hamstring strains with surgery. That's kind of her specialty. And she thought it was okay to just do conservative care. She wasn't concerned to do surgery. It was a quick, easy referral. They got the kid in quickly. She appreciated the referral, and, that was good. So, just keep that in mind. If you see a bunch of bruising, I wouldn't say you have to refer, but for certain types of hamstring strains, especially those proximal ones, if we're maybe a little worried about an avulsion fracture, might be worth just getting some imaging to see if that's something that should be treated surgically, or if the orthopedic wants you to just do PT as normal. So a little bit about bruising and edema there.
Yeah, that's a good point there. It's, when we think strain, oftentimes we're not thinking that there might be a potential surgery, but it's probably really good to talk about when surgery is advised and when it's not. I think I have one on my patient panel right now, which is not that common. And I treated one avulsion back in the day. And I just love telling the story because it's super fun. He was performing a Taekwondo kick and trying to impress his son. And he did this spinning kick and landed on ice and landed in a full split and avulsed the ischial tuberosity off. And his rehab went really well. But man, that's a bad way. You probably horrified your son trying to impress your son, right? That completely backfired. I know it's horrifying, but it's a little funny too sometimes. Little funny. Yeah.
Awesome. So this is my favorite slide I've ever made. If you have access to the video, we have a beautiful Gemini image here of a strong, fast, elderly woman playing field hockey. So you can check that out if you want to. But the reason why I put it there is because we're talking about risk factors, and we're going to look at non-modifiable risk factors. And one of them is older age. So hamstring injury incidence increased 6.4% for every 1 year of increased cohort age. So something to keep in mind. Older folks, older athletes are probably at slightly higher risk. Maybe that's because of the reduced fascicle length, but something to keep in mind. I would also guess it's probably sometimes due to the fact that if they're not looking at these confounding variables, maybe they've also had a previous injury of a hamstring strain. You're just older, you've had more opportunities to get one. Or if you're older and you haven't been doing the sport that you hurt your hamstring doing for a while, I could totally see that, like a dad beer softball league where you haven't played any running sports in a decade and then you sprint down first base and pull your hamstring. Yeah, that's increased with older age, but I think it's also increased with not doing the task at all for a long time. So I think that's how I think about older age, I guess. Like I said, for gender, males are at slightly higher risk than females. A previous history of a hamstring strain, so that you see different numbers, but 2.5 to 4.8 fold higher risk of recurrence. And then previous injuries to other structures seem to have some correlation. So if you have had an injury to your calf or groin, whether it's a calf strain or a groin strain, I think you're at slightly higher risk of a hamstring strain injury. And then ankle ligament and knee ligament injuries also increase risk. And again, my head goes to maybe deconditioning. Maybe they just haven't done a sprinting task enough. So now they're at higher risk of a hamstring strain. But those are some non-modifiable risk factors to just keep in mind.
Yeah, really good stuff, Kevin. I do have an old guy story that kind of illuminates this point. So I had a bunch of hamstring injuries back in college. I was a collegiate pole vaulter at Rutgers University, and I have had some strain injuries on and off. And then I think sometime around my mid-30s, I was at Power Monkey Camp, which is like an adult fitness camp. And we're doing this challenge. We had two teams going head to head. And we had one of those self-propelled treadmills, right, where you don't set the speed, but you go as fast as you want to. And the goal was to have the team run a mile as fast as possible in 10-second intervals. So the first person on the team would go on the treadmill and run 10 seconds. Second person would go, and we're going head to head with another team. So we're doing this, and I'm up, and I run as fast as I can, and I strain my hamstring, right? And I'm okay, but I go to the back of the line, and I'm like, all right, you still haven't won yet. I have to finish this thing. Should I jump back on top of this? Like, I'll give it a shot, right? So like basically, we don't have enough team members to complete the whole mile. We have to go multiple times. So my time goes up again, and I start limping aggressively and running as fast as I can with this hamstring strain. And I strain the other side. I had a double strain. But we got through those two bouts of 10 seconds, and I think my team won. So that's really all that mattered. But I was kind of hobbling around for the rest of the week, and I was like, man, that's like one of the dumbest things you possibly could do. But for me, I'm like that perfect example. Like I've had multiple recurrent issues in the past. I'm not used to sprinting in any way. Go out there and kind of hurt my hamstring. And we see this a lot too in folks that are kind of fit, especially as we go from like winter to spring. People are like, okay, going outside, let's do some hill sprints. And all of a sudden they strain their hamstring, right? And they're not used to running. Of course, they're going to strain their hamstring. I just thought kind of an interesting little anecdote for you there, Kevin. Hey there, you little learner. Do you like this content and want to go a little deeper with that learning? You should join us with our online community, Insiders Academy. It's our premium subscription membership to help you become a better coach and clinician. We do a lot of good stuff at Insiders. We fill in those gaps in knowledge that school didn't teach you. We go over things like exercise technique and prescription, programming, periodization, strength conditioning principles, and advanced rehab. Let's get you proficient there. We also help to keep you up to date on the latest medical literature, even if you don't have time. And we do this with cheat sheets. And these are PDF downloads that catch you up to date on a given topic in under 10 minutes. And we've got a lot of them, over 50, and we're constantly updating them and adding new ones. It's pretty much the exact same thing as downloading all of our knowledge directly into your own brain. We also keep you up to date with our master courses. We cover pathologies in depth so you know exactly how to diagnose and treat patients with these issues. And we're really thorough, going over prevalence and prognosis, risk factors, anatomy, history, clinical presentation, diagnosis, differential diagnosis, patient education, and exercise prescription, as well as manual therapies. We have a whole bunch of master courses, and we're always updating and adding new ones. Some of the big dogs are rotator cuff related pain, knee osteoarthritis, shoulder instability, femoral acetabular impingement syndrome, slap pathology, cervical radiculopathy, lateral ankle sprains, and radicular low back pain. Who doesn't love some searing back pain going down their leg? We also include case studies with every one of our courses. This way, you can see exactly how we diagnose and treat. Each master course comes with in-depth protocols, both non-op and post-op. This way, you know the exact exercise we'd like to use with videos of all movements, how many sets, how many reps, how do the exercises progress over the course of time, what are the relevant manual therapies when they're indicated, and exactly what you should educate your patient about. Hey, are you a physical therapist, athletic trainer, or physical therapy assistant and looking for some CEUs? Well, we got you covered, and you can even earn CEUs for watching the content you're watching right now. Finish up the master course, take the exam, get the CEUs. Easy peasy. With Insiders Academy, you also have community access. Basically, you can have all of your questions answered by me and the rest of our team at Fitness Pain Free. This way, as you go through the learning and you have a question, you'll get it answered. Best of all, you get started with Insiders Academy for just $1 for a week-long trial. After that, it's $25 per month. If you want to save 2 months, get them for free, then sign up for the yearly membership. I'm going to leave that link with a discount in the description below so you can check it out, and I'll see you there. Now, back to your learning.
Did you have bilateral bruising?
No, it wasn't too bad. Those weren't too bad in terms of strains. It's more my ego was bruised.
Oh yeah.
That was the biggest source of damage, I'd say.
I like it. So looking at modifiable risk factors, these are taken from, we have actually some clinical practice guidelines here from JOSPT from 2022. So you could always look at these. I think these are great. We see hamstring strain injury in athletes is the title of the clinical practice guidelines. So definitely check those out. And I think an important, interesting thing is weight and BMI are not considered risk factors for a hamstring strain injury. Flexibility is not considered a risk factor. There's low level evidence that shorter fascicle length is a risk factor. So that's kind of what I was talking about earlier. That's different than flexibility. That is the actual anatomy. So if the fascicle length is a little bit shorter, there's low level evidence that that is a risk factor. And that's what we see after injuries occur. So I think that mechanism makes sense to me. There's conflicting evidence whether the hip flexor and ankle dorsiflexion range of motion contribute to risk. So kind of unknown there, looking for more research to come out. In terms of muscle performance, there is a limited evidence, likely from the heterogeneity in studies, that found that reduced hamstring strength, particularly eccentric hamstring strength, to be a risk factor for hamstring injury. So I think another reason there, limited evidence, we need more to come out, but they're kind of hinting at is probably because of the quality and just the differences in studies that we're not seeing reduced hamstring strength be a modifiable risk factor. So in my mind, it would be one and something that we want to consider. So there's a little bit about modifiable risk factors.
Cool. One of my thoughts too is that, and I didn't read through this article, but is the hip flexor tightness because it may lead to anterior pelvic tilt during running? Was that kind of the thought?
Yeah, exactly. I think that's the idea.
Funny enough, when I strained my hamstring back in college, all we did was stretch. I went to the trainer and they gave me a book of like 17 stretches. Just hold each stretch for 3 sets of 60 seconds. No wonder I just kept on restraining it every single time.
Yeah, I was going to say that will prepare you to run as fast as you can and pole vault.
Yeah, it did not help.
Just a little bit about modifiable risk factors, just continuing that for a second. So considering muscle performance, I thought this was interesting. Increased peak quad torque is a risk factor for a hamstring injury. And then conflicting results as to whether reduced hamstring to quad ratio influences risk. So that was my first thought, is if you have a very high increased quad torque, maybe that is a reflection of a reduced hamstring strength. But there's conflicting results, right? Whether the hamstring injury to the hamstring to quad ratio is a huge influence. The other thing with increased quad torque, I guess I could picture that person is just a pretty robust, explosive athlete potentially. And maybe it's that reason that they're at a higher risk of a hamstring strain injury. So just something to consider. Eccentric hamstring muscle strength. So a study concluded that low levels of eccentric hamstring strength increase the risk of a future hamstring injury. Interaction effects suggest that the additional risk of a future hamstring injury associated with advancing age or previous injury was mitigated by higher levels of eccentric hamstring strength. So I like that, because if you did have a hamstring strain injury or you are an older athlete, we see the risk of an injury being mitigated if you have very high levels of eccentric hamstring strength. So that's a modifiable factor that we could definitely take advantage of in PT. And then I had talked about this a little bit previously, but this is talking about eccentric strength and muscle fascicle length. So a study concluded that the presence of shorter biceps femoris fascicles and low levels of eccentric knee flexor strength in elite soccer players increases the risk of a future hamstring injury. The greater risk of a future hamstring injury in older players or those with a previous hamstring injury is reduced when they have normal fascicle lengths. And we would see that with more eccentric training. So like I said, eccentric training is good because it's reproducing the mechanism of injury oftentimes. And also it's probably restoring some of the anatomy to what it was pre-injury. So I think these sources here from this clinical practice guideline are doing a good job of showing us that we can modify risk with eccentric strengthening, trying to restore some of that normal anatomy, and maybe we can reduce our risk of recurrence with that. So definitely good for us to keep in mind. Eccentrics are probably a no-brainer in the rehab approach to hamstring strain injuries, and something when we do talk about our next presentation on rehabbing hamstring strain injuries, it's definitely going to include eccentric exercises. And I think that's well supported by the literature.
Yeah. Good stuff there, Kevin. I do wonder about that quad extension torque, like why is that leading to more injuries? And part of me wonders is like, okay, if you have better quad extension torque, maybe just have like a bigger engine, and it kind of reminds me of like my son has like a power Jeep that goes like 2 miles an hour. And despite him being like 5 years old, it's kind of hard to hurt yourself with that, right? But if you're driving like an ATV around, it's like one of the literally the most dangerous things you can do. So I'm just curious if, to your earlier point, where maybe men are a little bit bigger, faster, again, nothing against women, but biologically they have a little more speed, right? Maybe they're just creating more risk for the nature of being more powerful. Who knows? Just kind of an interesting thought.
Continuing with risk factors. So we talked about this earlier, but match play versus practice, there's a 9.4-fold higher risk in match compared with training scenarios. That's probably just due to the intensity of training. On a training surface, there's a 1.5-fold higher risk on grass compared with artificial turf surfaces. I'm not sure why that would be the case, but that's what the studies here have pointed to. Sprinting mechanics with an anterior pelvic tilt are associated with an increased likelihood of a hamstring injury. And this is so hard to change, but that's just something to keep in mind. I don't think doing much static work on the table, stretching those structures is going to make a huge difference when you get up and start sprinting. But maybe working with the sprint coach, if that's something you have access to, or we've talked about a lot on this podcast, is a little bit of gait retraining, perhaps with increasing cadence, or just thinking about your foot striking under you rather than in front of you. Maybe small cues like that could be helpful in reducing anterior pelvic tilt, which the idea would be that you're presetting the hamstring with more tension. And if you're overstriding in that position, perhaps that wind up mechanism along the origin of the hamstring is creating more stress there. And that's where we're seeing hamstring strains. So, something to look at, something to consider, probably something to work on. And then another big one that I think we can intervene on a lot is training volume. So Tim Gabbett, who I know is a friend of Dave's, and I think has he been the champion? Is that right?
Yeah, he came a couple years ago. We went to watch him. It was good.
That's
I don't
awesome.
remember how many years ago it was now, but probably like, I want to say it was pre-COVID.
Yeah, it was before I was there, so it must have been. So yeah, he had a paper that was talking about what he talks about a lot of times, which is acute chronic workload, training volume, that type of thing. So it showed that exposing players, this is AFL's Australian Football League, to large and rapid increases and high speed running distances above their 2 yearly session averaged increased the odds of a hamstring injury. So if you look at what these folks did 2 years prior, and then you look at what they're doing right now, if there's a big discrepancy there, then they're at a higher risk of a hamstring injury. So always consider training volume and intensity, and how is that changing over time versus their usual training. And then another study showed that in Major League Baseball, the month of May had a statistically significantly higher frequency of hamstring injuries than any other month of the season. And if you know much about baseball, the season begins in April generally. So in May, we're still early on in the season. And this person or the athlete is probably doing potentially a lot more sprinting at this point than they were doing all off season. So I tend to think that's probably a reason to do some maintenance sprinting over the off season. Obviously, you have some deload is probably okay, but I think there's a reason we're seeing these injuries occur oftentimes in April and May in baseball players. I think that points to the fact that it's a big spike, kind of off what Tim Gabbett was talking about volume wise. So probably a good case to be sprinting all year if you are a sprinting athlete or your sport requires you to sprint. So I thought those were interesting considerations and things that we could intervene on as PTs, and we will talk about how we intervene on them when we talk about rehabbing these things.
Yeah, super interesting. I mean, one thing you're talking about is Gabbett. So Gabbett works with a lot of field sports, right? And hamstring injury is going to make up a predominance of that. So there's lots of hamstring injuries. And it does seem like the acute to chronic workload ratio holds true for these folks for sure. Whereas some other studies you'll see, in runners in particular, where some studies specifically show there's no change in injuries with increases in training volume or training intensity, which sometimes blows my mind. It's like, well, that doesn't make any sense. If I'm going to run a marathon, it's fine to just do it from the couch, right? Just get up and run it. I won't have an increased injury risk. So it doesn't really make sense always, but I think that you can say with some certainty, at least we have some research to show that for a population of field sport athletes, at least for hamstring injuries, the acute to chronic workload ratio has been tested. It probably is important. Does it apply to every other injury? Maybe not, right? The other thing that I thought was interesting is that, so Mike Reinhold has worked in professional sports. He's our boss. He's been working in professional sports for over a decade now. And hamstring injuries are, funny enough, very common in baseball players. Baseball players get like I don't know, they get knocked for not being like always super fit, right? But their sport is all explosive actions, right? And particularly sprinting. So I actually do a decent amount of sprinting, but it's always laughable because if you compare like the GPS data of like a soccer player to a baseball player, it's completely different, right? But baseball players still have a very high incidence of hamstring strains. One of the things that they would do that Mike was saying is that they count the amount of times they're basically running across the week, because for baseball games can be very variable, right? If you get on first base, then you probably sprint to get there. But if you don't, then you're not sprinting. So across of a week, you may have a very different amount of sprints. And one of the things that they'll do is they just track the amount of sprints. And on the weekend, when they're looking at the number and they're like, wow, you had a lot of sprints this weekend, we probably don't do any in practice. Or on the flip side, it's like, wow, you haven't gotten a base at all, or you haven't sprinted at all. Let's try to make up that difference to keep that acute to chronic workload ratio similar. I thought that was really interesting. The other thing, I will try to do this as well, and I have some videos on it, but A, B, and C, skip, march, and run drills are a way I try to work on pelvic position as well as striking with the foot right underneath of your body. I think that those drills are tough to teach. The reason why I feel like I'm able to do it is because I've been to a few seminars where they talk about these, but I also did them all throughout college. I did collegiate track and field in college, and we did like an incredible amount of A, B, and C skip drills. But to Kevin's point, I mean, if you're stretching someone's hip flexor, right, and giving them some cat cows and teaching them how to stay in neutral pelvic alignment, does that carry over to sprinting? My guess is probably not. But my second guess is that if you can use some of these sprint drills and teach these positions and progressively increase someone's running, thinking about these positions, I think you can maybe make some more permanent changes. So I would try to look at some of the A, B, and C skip and run drills on the YouTube channel. Just search for it. There's a whole bunch of those. So if you're interested, check it out. Hey, pardon the interruption, But if you're liking this content, I think I have something else that you're going to love. It's a free mini course where we go over solving some of the biggest problems that physical therapists are facing today. So, what are these problems? Number one, failing reimbursement. Medicare reimbursement has dropped 10% over the past 10 years, despite inflation going up 32% in the same time period. Documentation and admin overload. Physical therapists are often spending significant time doing notes and communicating with insurance companies, and this is often unpaid. High productivity quotas. Failing reimbursement rates force physical therapists to see more and more patients. Burnout and poor work-life balance. High productivity demands and extra work drive burnout. Insurance-driven restrictions. Insurance companies often cut patients off before they're ready, like ACL reconstruction patients, or they won't cover insurance for certain populations. Let's say a very athletic individual. They don't care about your athlete getting back to Olympic weightlifting. Debt versus pay and balance. The average student debt after graduation is $153,000, and our salaries are not matching this amount of debt. Lack of public awareness and referral dependence. Patients don't always choose PT first. They don't know our strengths as physical therapists, and they oftentimes will favor other healthcare providers. So how the heck do we solve this? We do this through a 6C process to help you start working towards that career of your dreams. And before we go into that, we got to figure out first, what do physical therapists want? So we want to be incredible clinicians. We want to be respected and valued. We often want to work with a specific population in a specific setting. We want to be able to practice the way we want to be able to practice. And generally, we want higher incomes. Now, given the current state of physical therapy, it makes a lot of sense that folks like you and I are upset. So in this mini course, we go over the 6C framework to get off the hamster wheel. It starts with clarity. What is the ideal patient that you want to work with? Next is connection. How do we become part of their community? Next is captivation. How can you help them with their specific problems? Next is competence. You have to learn how to treat these patients inside and out. Next is building confidence. That comes with time and reps, because perfect practice makes you perfect. And lastly, compensation. You want to get paid what you deserve. And this mini course will start you on your journey there. I help you to transform your career, start doing more of what you love and less of what you hate. This mini course is 100% free, and better yet, if you finish the course and then finish the quiz afterwards, which is nice and short, you can get 3.2 CEUs for physical therapists, physical therapy assistants, and athletic trainers. Again, it's 100% free. I'll leave a link in the description. Go ahead and click on that and download it, and I'll see you inside of the mini course. Now, back to your program.
Yeah, I think that's kind of like next level rehab, is thinking about what you were saying that Mike has experience with in baseball, is really looking at, like, you think, I had a game, I need to recover even if you didn't play much, but that's a good time to get your sprinting in if you didn't play, if you're a pitcher who just sat on the sideline, or if you didn't get on base. So that's a cool concept that I think you could apply to a lot of different things, is try to keep that workload as consistent as possible. Yeah, that's cool. So just the clinical course here, getting into the mechanism of injury. Like we've talked about, it's likely to occur during high-speed running or a stretching type injury. The patient is likely to report a sudden change of direction, a sharp pain. If they had a sudden change of direction, they could have a sharp pain in their posterior thigh, and they're likely to report an audible or palpable popping sensation. I've heard patients describe it as they felt like someone kicked them in their hamstring, or they felt like maybe they were shot in the hamstring, something like that. It's all of a sudden a very quick sensation. The healing process, it's similar to other injured tissues. So we think about just phases of tissue healing, right? So there's your inflammatory phase, takes about 3 to 5 days initially. There's your proliferation phase, which can take several weeks. And then remodeling can take up to 2 years. Just with muscle remodeling, it continues over time. It adapts to stresses. So, there's a lot going on under the hood. I think it's just cool to keep these things in mind in that first 3 to 5 days. Probably not going to get back to sport. You're in the inflammatory phase. There's a lot of healing going on. Probably want to just let that continue to do its thing. And then for clinical course, the return to sport varies, but generally 3 to 28 days are what you're seeing in the research. And that tends to be for your more grade 1s and grade 2s. Grade threes can take longer. They can definitely take up to even several months to return to play. So keep that in mind. Your more significant strains will take more time. MRI findings such as greater edema, multiple tendon involvement, or if the tendon's involved at all, proximity to the ischial tuberosity, these are all associated with longer recovery times. So your more distal hamstring strain might get back sooner. Your more proximal one, just keep in mind that could take a little bit longer. People always want to know how soon they could be back. So it's hard to give exact number of days, but people kind of get a feel pretty quickly of how quickly they're progressing, or are they having problems walking for several days? They're limping, they're having trouble reaching terminal swing, then we're probably going to take a little longer to get back. So the grades here do correlate with time to return to sport.
We don't always have that information. Maybe a reason to get some imaging if you are concerned, and then it gives us some additional information about how long this may take, right? I think that's kind of interesting. My second thought is the long remodeling times. Oh man, that stinks, right? It's funny because it's not a hamstring injury, but my calf. I mean, I've had these chronic calf strain injuries for years, particularly more recently in the past like 5 or so. I've had a heck of a time with running, and it's been about 1 year almost since I strained my calf last. I'm kind of curious if I'm getting to the point where I'm remodeling that muscle. I hope so. We'll kind of see. Time will tell. But interesting that it may take up to that long, and maybe gives people a little bit of hope when they feel like there's none. If they have these frequent recurrences, sometimes it just takes a little bit longer. Remodeling, unfortunately, it takes a lot longer than we'd like it to sometimes.
So we did talk about surgery a little bit, and there's a good paper here titled Hamstring Injuries, a Current Concepts Review, Evaluation, Non-Operative Treatment, and Surgical Decision Making. And this is from the American Journal of Sports Medicine 2024. So surgical intervention is reserved for complete proximal avulsions or high-grade tears with significant retraction, or if you have failed non-operative management. So there are those cases, like I said earlier, if you do have an avulsion fracture, that needs to be treated surgically. And if there is retraction, like your biceps tendon and like your Achilles tendon, it generally needs to be operated on sooner rather than later, where the tissue quality is still good and you can have a good surgical fixation. So if you're concerned of any of these things, it's probably best to just refer early and see if surgery is indicated, just so you don't wait too long and perhaps set this person up to fail with surgical treatment. Operative treatment of proximal hamstring injuries, including endoscopic or open approaches, is traditionally reserved for 2 tendon injuries with greater than 2 centimeters of retraction, 3 tendon injuries, or injuries that do not improve within 6 months of non-operative management. So keep that in mind. I think that's pretty good. So good evidence to suggest that early hip and knee range of motion and eccentric exercises contribute to less disorganized scar formation and lower re-injury rates. So if you don't have to do surgery, there is good reason to do some of those exercises early. But if you want more information on looking at surgical treatment, I think consider looking at this paper. I think it had some good pearls and good things to keep in mind from a PT referral standpoint. Hamstring injury risk is highest in those who have sustained a previous hamstring injury. So if we're talking about return to play and re-injury, obviously that's something to keep in mind. Those who sustained a hamstring injury recently are at highest risk of sustaining a subsequent one. So, I think, for example, with like Dan's calf, this probably relates. That was a year ago. He's probably at slightly lower risk of restraining his calf than if he were to get back to activity a month after. So if we're doing some good training and rehab in the meantime with the hamstring, we could think about the longer you are out from the injury, probably the more time the tissues had to heal, the more eccentric exercises and other good training exercises you've been able to do to remodel the muscle or the tendon, and probably do better and lower rate of re-injury. So that's something to keep in mind there. There's moderate level evidence that shows that the absence of an impairment-based functional exercise program as a risk factor for re-injury. So I think that's good for us as PTs. We want to implement impairment-based functional exercises. And not doing so seems to be leading to increased risk of re-injury. So a 2012 article found that risk of re-injury was highest when rehab did not contain agility and stabilization exercises, and including strengthening and stretching only. So another indication we've talked about a lot in previous episodes, that return to sport phase. When we get into our episode on actually rehabbing these things, definitely going to make sure that we're including agility, rehab, agility and stabilization exercises, and kind of return to sport based exercises, because we're going to do better than just strengthening and stretching alone. Moderate level evidence points to programs that do not include eccentric exercise as a risk factor for subsequent hamstring strains. So we're starting to piece together what elements need to be included in a rehab program. And not including them is actually, we're doing our patients a disservice, and we're probably increasing their risk of re-injury. So I think that's good stuff from this paper here, from BJSM in 2012. So a bit older, but I think, good information.
This is like kind of a weird story, but I came across this paper when I was doing a course with Dave Tilley about the shoulder, and I was trying to find rehab for pec strains, just because a pec strain is a muscular strain, but there's like zero research on it. So we tried to, and can be a little bit more common in like a powerlifting population. And I was trying to just draw some advice from multiple muscles, and the hamstring being probably the largest muscle strained or most commonly strained muscle out there. And what I thought was interesting about that study is that the agility was helpful for these folks. So one of the things I'll do for my hamstring strain patients is that I'll basically try to start them at the highest level that they can tolerate. So if they can tolerate running and some acceleration, I'll do that from, day one. But the other thing that, was interesting in this paper is like usually agility in the form of things like ladder drills and like shuffling is actually pretty low level stress on the hamstring. If you think about the hamstring, it's really strained or stressed with high speed running linearly. But when you're going side to side with like a shuffle, you have a different set of muscles that are kind of propelling you. It's more adductor and then abductor, right? So early on after rehab, that might be a pretty good idea. Just incorporate some of that stuff because athletes can feel a little bit more athletic, right? Outcomes are improved, and you're generally not putting a ton of strain through that hamstring. So just thought that was kind of interesting.
Totally. Yeah. I think so many things that we have to extrapolate, where we do have a lot of research for areas we don't, but I think that was a good idea because there's probably a lot of carryover. More on return to play and re-injury risk. So one review used return to play criteria based on a combination of clinical assessment and performance tests and reported mean return to play times of 23 to 45 days and re-injury rates between 9.1% and 63.3%. Two studies that implemented the Askling H test as part of a decision-making criteria reported mean return to play times of 36 days and 63 days with re-injury rates of 1.3 and 3.6%. That's a very low re-injury rate, which is why I think in our clinical practice guidelines and like the Aspetar protocol includes this, is including the Askling H test, which if you don't know is a test where the patient's lying supine on the table. They generally have their hips strapped down and they're kicking is with their legs straight. Oftentimes the actual test, I think they're in like a brace that locks their knee into extension and they're kicking as fast as they can, which is pretty scary. But if you can do that, you're probably pretty confident that your hamstring's functioning well. So people that are able to do something like that have a lower rate of re-injury risk. So something to consider. The most practical findings were noted in 3 studies that used isokinetic dynamometry in addition to clinical assessment and performance tests, with reported mean return to play times of 12 to 25 days and re-injury rates between 6.25% and 13.9%. So again, if we're using some objective measures, maybe we're seeing a little bit lower re-injury rates compared to ones that aren't using objective measures and ones that are pretty robust and challenging. So there's moderate level evidence that shows that clinicians should gather pertinent information at the time of the initial evaluation to inform return to play. Hamstring strength pain level at the time of injury, number of days from injury to pain-free walking, and the length or the area of tenderness measured at the initial evaluation are useful tools to estimate the time to return to play. So things that we might want to gather on our assessment to think about when can this person return to play and what their re-injury risk might be if we get back too soon.
It just comes back to that whole discussion. It's hard to know because it's like, was it 13% to 63%? That's tough. I guess if you have an injury that seemed fairly severe, you're maybe a little bit more likely to hold back a bit longer, right? Maybe some extra bruising, so on and so forth, if you don't have additional information. It's just so tough to give information to patients about when it's actually safe. I just try to educate them about the risk and then seeing if they're willing to accept the risk or not. Sometimes it's a tough conversation because patients really want to get back and they just basically want me to say, yeah, it's safe to get back. When in my mind, it's not. So I try not to give them that information. But yeah, it's decision-making process. What games are coming up? What's important? What's not? Can you communicate with your coach and figure out how you can make this happen in a way that's safe? Just because I think for a lot of, younger kids, they just don't want to talk to their coach. They don't want to say no. They want to I'm thinking about a young athlete I had recently that I want to say 15 years old. And what he's doing right now with baseball, there's nothing that's super important coming up, but he has a ton of these tryouts where they sprint on every single one of them. It's kind of like, are these really that important? Right. Because what can happen for a lot of these folks is that they get hurt and then they rehab a little bit and they get hurt again and they rehab a little bit. And they just get into this point where they're having these recurrent hamstring injuries. We just don't want that to happen. I would say that it's just risky. Some folks do A-okay and some folks not, but use your clinical reasoning as best you can and just educate patients, let them know that there is a risk if you do return sooner, right? But that's tricky to know just how at risk you are versus not. But the Askling, those numbers were tiny. So 1.3, 1.6. So I'd say at the very least, if they can pass that, then you're pretty confident that the risk is lower, right?
And the return to play times were longer with that, So I feel like the confidence it takes to pass that test might take longer than the 3 to 28 days that we typically think of getting back. So yeah, pretty interesting. Hopefully we get better return to sport tests with hamstring. And we didn't include this because we're not doing the rehab right now, but I think it would be important to obviously successfully complete a return to sprinting program. If you have the time to, like you said, if something's coming up and you have to cut rehab short, they're probably taking an increased risk in your hamstring rehab. But if you have time to go through and actually complete a sprinting program, you're probably confident that I bet you would see similar things to that Askling H test for lower rates of re-injury because you've done harder rehab that is more similar to the demands your hamstring sees during sport. So just something to consider. But just a summary here of return to play and re-injury risk. So one, gather information about previous hamstring injury and injury time interval considerations. So do they have a previous injury? How long has it been since their previous injury? Sometimes you'll see people in PT who are coming to you after their second or third hamstring strain. After the first one, I think like Dan had said earlier correctly, a lot of times we think of these like ankle sprains where people will pull their hamstring or roll their ankle and just not seek out medical care right away. They kind of figure that this will just get better on its own and they feel better with ADLs very quickly. And then they go back to sport and they restrain their hamstrings. So they might have already had a few strains by the time we see them in PT. And then in order of importance, according to this paper, I believe this might be the clinical practice guidelines, but the following variables were most predictive. Oh no, this is a paper by Rod Whiteley where they do kind of like regular testing of the hamstring after someone had a strain and they figure out what was most predictive for return to play. Number one, a change in strength during the first week for the mid-range test. So these are different tests to test the hamstring strength with a dynamometer. A mid-range test is someone's on their back with their hip at 90 degrees and their knee at 90 degrees, and they're doing an isometric test for their mid-range hamstring strength. Also, peak isokinetic knee flexion torque of the uninjured leg at day one. Number three is pain level at the time of the injury. Number four is days to walk pain-free. Number 5 is playing soccer. Number 6 is inner range hamstring strength at day 1. Number 7 is the presence or absence of pain on a single leg bridge at day 7. Number 8 is a delay in starting physical therapy. And number 9 is the percentage of strength in the outer range test compared to the healthy leg. So if we consider all these things, they're most predictive of return to sport. If we're looking at these early on in rehab, we can consider that if patients are hitting some of these things, they might return to sport early. If they're having, for example, like number 4 days to walk pain-free, it's taking a week or more to walk pain-free, probably going to take a little longer to return to sport. So things to keep in mind and perhaps help you hypothesize when the patient will be back to their sport. And then number 3 here for summary, I think consider using the Askling H test to clear the patient in conjunction with other clinical tests and measures. That seems to be one of our best tests right now, if not the best at predicting future injury. So if the patient can pass this, probably feel pretty good that they are cleared or ready to return to sport. And hopefully their risk of re-injury is a lot lower than we see in most studies because we're giving them a pretty hard task to complete before returning to sport. So hopefully that helps with the return to play and assessing the risk of re-injury.
All right, guys, if you like this content and want to earn some CEUs for physical therapists, physical therapy assistants, and athletic trainers, then you should check out Fitness Pain Free Insiders Academy. I'll put a link in the description. It's $1 for 1 week trial, followed by $25 per month. And you can gain your CEUs just by watching videos like this one. And if you're looking for another video that's completely free, I'm going to leave a link over top of Kevin's head where we go over the number 1 most common lower extremity injury, patellofemoral pain. We'll see you there.